So for our first speaker, I'd like to welcome Dr. Imran Butt, an endocrinologist and general physician based in Brisbane, to discuss fasting smart with diabetes.
Assalamu alaikum, everyone. My name is Imran. I am an endocrinologist based in Brisbane. We have a very limited time, so I'll jump straight to the topic. So we will be discussing the safe and practical approaches for diabetes management in Ramadan. It's a very long topic to be covered in 15 minutes. However, with our moderator keeping a close eye, I will try to keep this short yet useful. So my talk is based on recommendations made by International Diabetes Federation along with the other national and international societies. And these recommendations have been endorsed by the highest religious authorities, including International Islamic Fiqh Academy. Today, I'll be covering the key hormonal changes that occur and how these significantly affect people with diabetes, and also the physiology of Ramadan fasting. We'll also look at risk assessment followed by case-based examples and how to adjust medication safely during Ramadan. There's a lot to cover, so let's dive straight in. Clinicians often lack Ramadan-specific experience, especially in a country like Australia. Some patients also avoid telling doctors they plan to fast because they fear being told not to. So education is often late or absent. Many people with diabetes choose to fast despite medical exemptions. So our role isn't simply to say don't fast, it is to assess risk, educate, and reduce harm. During non-Ramadan days, we have breakfast, lunch, and dinner at specific times, and the sleeping pattern is continuous from night through to early morning. However, during Ramadan, these sleeping and eating patterns are more fragmented, and this can profoundly impact the circadian pattern of body with consequential metabolic effects. So blood glucose is regulated by several hormones. Insulin lowers it, while cortisol and growth hormones and other listed on the left side raise it. Cortisol peaks in the morning and growth hormone during early sleep. So poor or fragmented sleep disrupts this balance and can increase your blood glucose. This graph shows cortisol patterns in 23 participants before Ramadan and on day 7 of fasting. Normally, cortisol peaks in early morning, but during Ramadan, the peak shifts earlier and the evening levels are relatively higher, suggesting a change in circadian rhythm that may contribute to high glucose levels later in the day. In terms of physiology, after we eat carbohydrates, blood glucose rises and it stimulates insulin release. Insulin allows glucose to enter muscle cells for energy production, while excess glucose is stored in the liver as glycogen or converted into visceral fat. And during fasting, insulin levels fall because less glucose is available. And in response to this, glucagon and catecholamines increase, prompting the liver to release stored glucose into the bloodstream. In people without diabetes, this balance between insulin and counter-regulated hormones is tightly regulated. However, in diabetes, insufficient insulin allows counter-regulated hormones to raise blood glucose by releasing the liver stores. Because insulin is required for glucose to enter muscle cells and there isn't enough insulin there, the glucose remains in the bloodstream and the body's energy requirements go unmet. And as a result, fat is used as an alternative source of energy. And when fat is broken down, it leads to ketone formation, which becomes excessive in the absence of sufficient insulin. And it may result in ketoacidosis, which makes you feel really sick, especially if you have type 1 diabetes and there is not much insulin on board. On the other hand, if we continue the usual doses of insulin and diabetes medication while fasting, it can reduce the blood sugar too much, causing hypoglycemia. So balanced diet, supervised changes in medication by a specialist are crucial for safe fasting. Now, the real question is, can individuals with diabetes fast during Ramadan? Most of the literature shows many people with type 2 diabetes can fast safely, but with education and medication adjustment, but not everyone. There is this structured risk assessment which we use with points assigned based on history, examination, blood tests. And the patients are then categorized as low, moderate, or high risk. And those in the moderate and high risk are advised not to fast. This tool is also now available online on MDCalc. Just click the relevant numbers there and it calculates your risk. It makes your life easier instead of remembering all those numbers. If we have time at the end, I will show you how to do it, but this is just a screenshot. So coming to our hypothetical cases, the first one is called Mr. Ali, who is a 57-year-old gentleman with 20 years history of type 2 diabetes, and he's normally on Novamix, and he's currently injecting 20 units with suhoor and 20 units with dinner, and he's also on metformin and glycoside. His last HbA1c 6 months ago was 5.4%, indicating a very tight glycemic control. So he comes to see you in a clinic. He's been fasting for 13 hours. He looks unwell, profusely sweating with trembling hands, and his heart rate is high. So in this case, likely diagnosis is symptomatic hyperglycemia in context of prolonged fasting and insulin on board. So first action to do is to immediately give him a fast-acting carbohydrate in the form of glucogel or glucose, honey, or whatever is available, and check the blood sugar at the same time. And it's important to counsel the patient that this is an emergency situation and religious exemption applies in this case. Now, we should also check the blood sugar again in 15 minutes, and if it's still less than 3.9, we should give him another glucose load. Given there's a lot of insulin on board, there is an increased risk of hypoglycemia in next 24 hours as well. So he shouldn't be driving for at least 30 minutes and until his blood sugar stabilizes. He should have a snack as soon as gets home or if available at your clinic. And he should be checking blood sugar more frequently for next 24 hours and temporarily relax his glycemic targets, even up to 10 to 12 is fine for next 1 to 2 days. We should also check the kidney and liver function because if they are impaired, that will increase the risk of hyperglycemia. With ongoing fasting in this case or in other patients, they need to check blood sugar more frequently during the day, and they need to break their fast if the blood sugar is less than 3.9 or greater than 16.6 or symptoms of hypo or hyperglycemia, which we can discuss at the end. So early falls in high risk.
Attention all personnel. Please be advised we have a code red activation. B block ground floor. Section wardens, please follow your action cards.
I apologize, I'm still at work. So
attention all personnel. Please be advised we have a code red activation. B block ground floor. Section wardens, follow your action cards. Please have fire and rescue are on red.
Oh dear. All right. So early falls in high risk, and he should be advised not to fast. However, as expected, he wants to fast for the remaining days of Ramadan, and given there's a high risk of hypoglycemia. So in terms of ongoing fasting, we should reduce his Novamix by 25 to 50% at suhoor time, and he can continue to have usual Novamix at iftar time. And if there are blood sugar spikes after iftar, we can always adjust the insulin or give him another short-acting insulin. In terms of glycoside, I would prefer to switch it to another agent which does not cause hypos, one of the gliptins, or if we decide to continue, it should be given after iftar. No change in metformin as long as the liver kidney functions are fine, as it doesn't cause hyperglycemias. With regard to any other patients who are on other medications, for example, SGLT2 inhibitors or GLP-1s like Ozempic, they are considered safe while you're fasting, but do not commence during Ramadan. I would prefer to commence them like at least 4 weeks prior to Ramadan. And if they are already on SGLT2 inhibitors, they should take it after iftar because there's a risk of ketosis if you're fasting. In terms of other insulin doses, they also need to be reduced, and they need to see a specialist because they will need to change their doses frequently. So Ali also inquires about exercise and diet. So with regard to exercise, only light to moderate exercise should be advised, and it's best to do that after iftar or at night, as there is a reduced risk of hypodehydration during that time. He should also be advised to eat meals that are balanced and include food with low glycemic index and high fiber content. For example, plenty of fruit, vegetables, and salad. And the low GI diet provides slow glucose release and better for long-term energy. And he should also avoid high GI foods as they cause rapid glucose rise and lead to energy crashes. And she should also avoid caffeinated or sweetened drinks because they increase your blood sugars. He should also divide calories between sahur and iftar, with sahur being the largest meal, and use complex carbs, high protein diet, and plenty of fluids and for hydration. Coming to our case to Mona, who is a 19-year-old lady with type 1 diabetes diagnosed at age of 15. And she comes to see you at a clinic, with the 5-hour symptoms of polyuria, polydipsia, and drinking a lot of water and passing urine, with nausea, vomiting, and abdominal pain. She's usually on 24 units of aptisoline and 6 units of Novorapid with meals. However, she has cut down her long-acting aptisoline to half, 12 units, and she's taking her Humalog, which is short-acting, only before iftar, not with sahur, assuming that she needs less insulin. And she's right, but she's doing it in the wrong way. And she looks really unwell with the dry skin. She's, tachypnic. So in this case, the likely diagnosis is diabetic ketoacidosis. And these are the examination findings which you will be looking for. And also, to the abdominal examination, she might be very tender because the acidosis increases visceral hypersensitivity. And you will be looking for any triggers of decay and any infection on examination. We would immediately check her blood sugar at ketones and send her to the hospital where she will be formally diagnosed with DK and have treatment with IV insulin, fluids, electrolyte replacement, etc. In terms of the ongoing advice for fasting, she's a high risk, so we should advise against fasting. However, if she insists, I would reduce her aptisoline by 30 to 40% at iftar, and normal dose of Humalog at iftar, but reduce it by 25 to 50% at sahur, which she was not doing at all. And if she's not eating, she doesn't need any short-acting insulin. As she was on a fixed dose of Novorapid and she has type 1 diabetes, she needs to learn carb counting, which will give her a better glycemic control. And she should wear CGM because it's subsidized for type 1, and I will come to that in my next slides. And she should have a printed and 6-day plan. She can paste it on her fridge so she knows what to do when she's unwell. Other patients who are based on basal bolus insulin or insulin pumps, they also require specialist review because insulin doses and pump settings need to be changed as well. There are different mobile apps available for calorie or carb counting. For example, this one is Calorie King. You can search up food by name, brand, and it gives you detailed calories and carbs. It's great for people with type 1 diabetes who require carb counting for insulin administration. Other option is the Easy Diet Diary, which is also great, especially if you are preparing meals at home. You may need help from a diabetes educator to learn more about these apps. CGM is a technology that tracks glucose levels in real time throughout the day and night. And in Australia, we have Libre and Dexcom, which are widely available. But unfortunately, they are expensive. And to date, they are only subsidized for type 1 diabetes. Although I do not have diabetes, but I tried CGM in Ramadan last year to check my blood sugars. And this is my personal data. And I was on totally protein diet and no carbs. And you can see throughout the day, this gray shaded area is a normal range, 4 to 10. And it was like my blood sugar was pretty flat, even after sahur when I was just eating protein, just meat. However, after one ashra, I think my wife felt a bit jealous, and because I was looking a bit slimmer, and she made a paratha for me at sahur time, and I had a large blood sugar spike there. As I do not have diabetes, insulin kicked in and it brought back to in the normal range. Now, just imagine if there was not insulin there, how high it would have gone with just one small paratha. And that's another day at the iftar time when I had just a couple of sips of a sweetened drink, and there was a bit of spike there as well. And this is a study, a Ramadan study, where different people were monitored on CGM, and this blue line indicates their blood sugar control in non-Ramadan days, and the same individual had the CGM monitoring during Ramadan, and you can see the large spikes at iftar time. So we have a lot of data which indicates blood sugar improve if you put CGM on in type 1, but there's also no data available in type 2 diabetes as compared to finger pricking. There's better glycemic control and more time in range as well. But unfortunately, it's a bit expensive. So hopefully we will have subsidy on type 2 patients as well who are using insulin. But the point is that if you watch your sugar, you can control it, and CGM is a way to go. So this is a summary of a management algorithm, and I would like to say that Ramadan is about partnership, not prohibition. With risk assessment, education, monitoring, and medication adjustments, many patients can fast safely, but high-risk ones must be counseled clearly and compassionately. Our job is to make Ramadan safer, not scarier. There's a lot of online help available. There are different blogs, so you can go on Diabetes Australia and search up these ones, and you will find some useful information there. So my 2 cents for safe Ramadan: assess your risk and watch your sugar, preferably with CGM if you can. So this is just the last slide on managing hypothyroidism. Many of the patients with diabetes are taking thyroxine, or even without diabetes, they may have hypothyroidism. But thyroxine absorption is reduced if you take it with other meals or foods with full stomach, iron or antacids. So during Ramadan, timing is challenging due to rushed suhoor and social iftar meal. So dosing may need to be individualized. So one option is to have a late night dose if no heavy food is eaten after iftar. So you can have it at your bedtime. Thank you so much. Hope you all have a great Ramadan.
Jazakallah khair, Dr. Butt. That was an excellent presentation, and as we know, diabetes is all too prevalent in our community, and so it's crucial that we're equipped with the know-how on how to support both our patients and family members that may be affected, especially like that app that you had mentioned, Calorie King. I hadn't heard about that before, so it's very useful to tell our patients. There are just two brief questions, if you have just quick 30 seconds to address them. Just those who are low risk on tablets, I presume just metformin, any particular changes, or you would say that they could continue?
So metformin and glutens you can continue because they don't cause hypoglycemia. As you know, sulfonylurea they increase your insulin, so you have to be careful. And with insulin and GLP-1s and SGLT2 are also safe, but don't initiate them during Ramadan. As with vegetarians and others, you just need to give it after iftar. So most of the tablets are safe except gliclazide because that increases your insulin.
Thank you. And does fasting affect decision making from a surgeon's perspective in terms of if they have diabetes as well and deciding to do surgery, I presume?
Yeah, it depends on how their glycemic control is. I think they shouldn't be bad. Obviously, they wouldn't be fasting, or they would if they're going to have surgery the next day. But if they have a good glycemic control, they are fine.
Okay, Jazakallah khair. Thank you.